state level webinar that is being conducted after the installation of the new team of office bearers and led by Dr. Samuel Kashi as the state president. Today we have the very important topic of antimicrobial resistance. I request the state presidents to call the meeting to order.
Thank you, Dr. Gobi. Meeting is called to order. We'll have a silent prayer for 30 seconds. All will be sitting and participating in the silent prayer.
Thank you.
So now it's welcome address by Dr. Gobi.
Yeah. Thank you, President. Respected State President Dr. Samuel Koshi, immediate past President Dr. Sakaria Sir, National President Dr. Jayalal, HSG Dr. Jayesh Lele, and National Action Committee Chairman Dr. Mathandapulla, and our the esteemed faculty, our good friend Dr. Padma Kumar and Dr. Jitin, and senior IMA members, past presidents, and executive members and friends. Today, a very important topic we are going to discuss. As you are all aware, probably the biggest challenge in treatment, especially in infections and infectious diseases, and in the usage of antibiotics, is the antimicrobial resistance. Over the years, Kerala state government and Indian Medical Association have been associating together to combat this menace in a particular way. We had already had some 3-4 meetings with the state government in the previous years over a span of 5 years time. But now this has been taken up in the national level, and the national IMA is arranging webinars throughout the country, and each state is conducting webinars on antimicrobial resistance for their particular states, for the awareness of the members of Indian Medical Association and modern medical practitioners. As practitioners, the practicing physicians and surgeons of modern medicine, it is very mandatory that you should know about the judicious use of antibiotics and why and how the antibiotic resistance is being developed. What are the precautions you have to take? What are the awareness that to be given to including the patients? But because there is high literacy in Kerala state, probably many of the patients, many of the people, they themselves prescribe antibiotics on their own, and that also causes to a lot to this menace of or the greatest challenge of antimicrobial resistance. Today, we have with us our state president, who is presiding over, Dr. Samuel Koshi. And yes, welcome, sir. Dr. Jayalal, the national president, has joined us. So just into the welcome address, sir. Okay. Now, welcome Dr. Jayalal, who has been very instrumental in giving us opportunities to have enough activity and supporting us from all angles of activity of Indian Medical Association. He has been with us many times at our headquarters and in Kerala. Very warm welcome to you, sir. Next, we have our Honorable Secretary General, Headquarters Secretary General, Dr. Jayesh Lele. I don't know whether he has joined anyway. I welcome him also to this function. We have our State President, Dr. Samuel Koshi, the immediate past President, Dr. P.T. Sakaria, and our National Action Committee Chairman, Dr. Mathandapulla, all for this particular CME for the webinar, and I extend a warm welcome to all these leaders. We have two esteemed faculty, our own IMA Alapura member and chairman of Epidemic Control Cell of IMA Kerala State Branch, Dr. B. Padmakumar, who will be dealing with one of the topics, and Dr. Jitin Raj, who is Assistant Professor in the Department of Neurology, Government Medical Alepura, dealing with the second topic. And I extend a warm welcome to each and every member who is participating in this webinar. We have the past state presidents, we have state office bearers, we have local branch members, we have the executive committee members, and our beloved IMA members of all over Kerala. I extend a very warm welcome to each and every one of you. Thank you.
Thank you, Dr. Govi.
Next is, yeah.
So the next we'll have the address by me. Most respected President of Indian Medical Association, Dr. J. Jailal, Secretary, Honorary Secretary General, Dr. J.S. Lele, our Action Committee, National Action Committee Chairman, Dr. Matanula sir, our IPP, Dr. Sakriya sir, beloved Dr. Gopi, other dignitaries, honor of the dais. Let me also first thank our National President, Dr. J. Jailal, for joining us in spite of his busy schedule. He, I think, is traveling and he's in the airport. From there only, he is joining now. Thank you very much, sir. As we all know, antimicrobial resistance against antibiotics is on the increase. The importance of this resistance is known to all practicing physicians and surgeons, because the resistance is so high that whenever we use an antibiotic, suddenly we find that the organism has developed resistance against that specific antibiotic. We'll have to move on to the next level of antibiotic. This goes on like. So antimicrobial resistance is a very important issue all the physicians and the modern medical practitioners are facing now. Judicious use of antibiotics, as has been mentioned by Dr. Gopi, is very important. There are many challenges ahead in this aspect. Many over-counter sales, even antibiotics, are happening in our country. Non-modern medical practitioners are using these antibiotics, but still, all our modern medical practitioners should practice the system of judicious use of antibiotics. Then only we can overcome to a limit, at least, in this regard of antimicrobial resistance. So with these few words, let me entrust the further proceedings to Dr. Gopi. Over to Dr. Gopi.
Thank you, State President. After the presidential address from Dr. Samuel Koshi, we'll have the inauguration by our beloved National President, Dr. J. Jailal sir. Sir, please.
Thank you very much, distinguished President of the Kerala State, Dr. Samuel Koshi, the vibrant Secretary, Dr. Gopi Kumar, my beloved friend and senior leader, the immediate past State President, Dr. T.T. Sagaria, past State President, Dr. Sugadan, Dr. Devadas, Dr. very distinguished leaders, Dr. Mohan Rai, Dr. Kavidas, Srinivasan, M.N. Menon, and other distinguished members. I'm extremely happy and delighted to be with you and inaugurate this program. I'm right now in Jharkhand. Morning we had a women doctors being program and a very, very important cervical screening program organized by along with the government of Jharkhand, with the health minister and the health secretary. It was a very wonderful, massive cervical screening Swayam project, which the Indian Medical Association and the Jharkhand IMA are able to do that. Just entered into the airport and catching the flight for Delhi. I'm happy that throughout the country, through the Indian Medical Association and our association with the GSK, this AMR program is being organized, because the Indian Medical Association family believe this is one of the very important responsibility as a medical fraternity we are having. In 2014, when the WHO formulated this theme, and if the no action, and it will be the consequences will be very bad, like things they put that theme on the 2014 on the antimicrobial resistance. At that time also, Indian Medical Association actively formulated a Chennai declaration on the AMS, which was still followed in many countries and many areas, which has been accepted throughout the world for implementation of the AMR. Today, we are living in a very important era because every 45 seconds, almost one patient is dying due to the microbial resistance which is happening. On some date, we have nearly 7 lakhs people are dying, but it is projected when the 2045 to 50, 10 million people will be die with antimicrobial resistance, which is much higher than the cancer death, which is projected, which is only around 8.2 million. So that means today what we have nearly the drugs which are sensitive to the many diseases may not going to be sensitive in the future days when we have. We already seen that right in front of our eyes, many people are dying. Very recently, we lost one of the very famous cardiothoracic surgeons who got the multi-drug resistant tuberculosis, and none of the drug could save him. So we lose people with malaria. Nearly 23% of malaria is becoming drug resistant, and nearly E. coli extended the Escherichia coli enterobacterial resistance are increasing. The very painful thing is even the colistin is having 21% resistance for the drug, which is ultimate drug which we believe in that. The challenge we face is the new drug coming is very low. On the drugs which are in the pipeline, the new method of drug, it is going to come is very less. So unless we work hard and sensitize our people on the antimicrobial resistance, it's going to be a disaster for our country. We know for sure it is not only our medical fraternity, because the quackery, the animal husbandry, where there is nearly 40% of the drugs, antibiotics are used in animals, even the poultry, apiary, the honey preparation. There are so many other areas where the antibiotics used. That is why Government of India now formulated a national action plan, which comprising of a one-way approach, in which the 3 departments are put together: the Health Ministry, Animal Husbandry, and the Food and Nutrition. So all these are coming together and working and formulating various means and ways by which that we will be able to come down. But having said that, why Indian Medical Association is interested is one of the 50% of this contribution is from our own doctors. It is our own members of Indian Medical Association who still prescribe drugs for the viral disease, who still prescribe drugs for the viral diarrhea, or sometimes comes with otitis media or small infection where there is a possibility of no need for the antibiotic, we still prescribe. When we do a surgery, we are prescribing the 7-day course of antibiotic, which the scientific evidence all prove that the single dose prophylactic antibiotic is much effective. But that habit of not adhering to the rational use of antibiotics is still rampant in our doctors. Irrational drugs there, combination of the drugs are there, and we are not having an adequate infrastructure testing laboratory where which will be able to give as which are the sensitive drugs, which are the resistant drugs, like what we have in the CBT, CB0, where the tuberculosis and we are doing, it will tell us whether the ribamycin is sensitive or not. Similarly, we do not have full.
So you are getting muted. So,
Yeah, no, sir. It's a net problem. It's the net problem. It's okay. I think he's.
Yeah, microbiological lab is not there, so that still we find it difficult. But at this moment, what is our desire and what is our interest is to make sensitize our doctors. But equally, it is a challenge in front of our doctors to use non-antibiotic approach to antimicrobial therapy. There is a newer development of the phage therapy. There is bacteriophage, which is a virus itself. It can enter into the bacteria where it can kill them, or the fecal transplantation, monoclonal antibodies. So many newer techniques of non-antibiotic approach is coming. But most importantly, and we want to emphasize the hand washing, the basic adequacy of the sepsis prevention. Suppose there is an abscess, doing the INT much earlier, putting the catheter for a long time, it should be avoided, or the putting a catheter, Venflon for a long time. So all these, the infection control is the most important strategy which we want to employ on that. So all this put together, this is the dream of our Indian Medical Association. Our contribution of 50% to the antimicrobial resistance can be reduced further by building awareness, building strengthening, and emphasizing on the infection control and interacting and research methodologies where that non-antibiotic approach to the antimicrobial will help us. But this seminar is organized throughout the country. I'm happy that every state this is being organized. A lot of people are joining. We need to extend this to medical community, medical colleges, medical students, and junior doctors. And we are very particular that this message should go to our future doctors also. I wish and hope IMA Kerala will also take up this issue in penetrating and percolating this message to our branch doctors so that we will play very, very sensible, conscious role in bringing down the antimicrobial resistance to save our future generation from dying in front of our eyes without the effects of a drug. So thank you very much for actively doing this. I'm happy to see more than nearly 100 people have joined, and that is a good show. And I'm so happy Kerala will, as usual, always will take this positively and do effectively this program. Thank you very much for this opportunity to be with
you. Thank you very much, sir, for joining us
Yes,
and inaugurating this. And actually, there is a clarification, sir. In fact, I have completed my 2 years of state secretaryship, and the new secretary has taken charge because he is in another meeting.
He's engaged in another program.
That's why Dr. Joseph Benavan is the new state secretary. Thank you, sir.
Dr. Joseph?
Joseph
Benavan.
But Dr. Gobi is the senior vice president now.
Yeah.
Okay, fine. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much for joining us. And I don't think our quarters secretary general has joined.
IPP is there. I'll call the.
Okay. Sir, Sakaria, sir.
Yes. I am glad to hear this topic from the national president itself, because he is a professor in a medical college teaching institution, and he was rightly pointing out. My point is there is no newer antibiotics is coming in the pipeline. The production new antibiotics are not there, and whatever we have are already been misused. Most I remember one presentation from Chennai once before so many years that urinary infection has become totally drug resistant in some centers, and now we can. മലയാളത്തിൽ പറഞ്ഞോട്ടെ സാറേ.
No issues.
നമ്മൾക്ക് ഈ ഒൾച്ചേഴ്സ് ഉണ്ടല്ലോ, നമ്മുടെ ഈ ഡെഡ് ആനിമൽസിനെയൊക്കെ തിന്നുന്നത്, അതിന്റെയാണ് ആദ്യമായിട്ട് നമ്മൾ ഡൈക്ലോഫിനാക്ക് ഐസൊലേറ്റ് ചെയ്തത്. വളരെ ഒരു നോൺ ജുഡീഷ്യൽ use of diclofenac. That is not an antibiotic, of course. It is an anti-inflammatory drug, but it was seen in enough quantity in a dead vulture. That means that all antibiotics in triple dose is used by veterinarians. We are now in good relationship with the veterinary department. They have invited me for as their chief guest in conducting a World Zoonotic Day. And I went there. I met even the minister and secretary for veterinary department, IAS officer. Everybody was very, very appreciating my talk based on One Health. That means humans and animals all live in this world in a mixed way. So we cannot isolate. And now today, even a newspaper carried a news of bird flu in my district, Alapi, and so many infections are coming from that side also. So we have to be very careful. And one of the best persons I know, Dr. B. Padmawar from our medical college, he is one of the speakers here. Please, I wish you all this success in this, because we had conducted 6 years back the same topic, and that has been very highly theoretical. But Padmawar is a man among the public, so he can contribute a lot, I hope. And Shamal Koshi, thank you very much for conducting this seminar in the state level. Thank you.
Thank you, Sakaria sir.
Sir will be joining now. Lele sir is not picking up the phone. Matanula sir will be joining now.
Okay, so we'll have Matandabula's address and then go on straight to the CMA program, isn't it? And meanwhile, I'll just introduce the faculty today. Of course, Padma Kumar needs not no introduction, as he was the chairman of Epidemic Control Cell last year, and he came out with a beautiful book for Indian Medical Association, which is for the general public, creating awareness regarding the precautions to be taken during an epidemic of infectious diseases. Now, he is the professor and head of Department of Medicine, Medical College Alappuzha. He's a alumni of TD Medical College Alappuzha, is a rank holder and gold medalist for MBBS. He has a PhD in medicine from Kerala University and fellowship in rheumatology from Nizam Institute, Hyderabad. He did his post-graduation MD from Government Medical College, Aurangabad. And he has been awarded the Best Doctor Award from the Government of Kerala in 2011. And he's author of 25 books on health education. And he's also the Joint Secretary of Indian Medical Association, Alappuzha. He's a life member of IMA through Alappuzha branch. And the second faculty is Dr. Jitin Raj. He studied MBBS in the Government Medical College, Kozhikode, and did his MD General Medicine from TD Medical College, Alappuzha, and DM Neurology again from TD Medical College, Alappuzha. He is a consultant neurologist, has joined the TD Medical College services, and he has enough number of publications in the Journal of Neuroscience. And welcome Dr. Padma Kumar and Dr. Jitin Raj to this function. And meanwhile, Matandabula sir has joined, sir. We would like to hear from you on this particular occasion. Thank you.
Thank you. Let me at the outset itself State Branch for taking up this very important topic. That is antimicrobial resistance for discussion and for awareness. The antimicrobial resistance is really a problem that we are facing. Every medical practitioner is facing.
The voice is getting
right.
Our cherry net issues.
Okay. So we had to basically we had to have even a hospital. Every hospital should have an antibiotic or infection control committee, which should analyze the prevalence of infection, resistance of the organism to antibiotics, and plan it. And if it is a very small hospital, at least 3 or 4 or 5 hospitals together should have such a committee, so that prophylaxis. I'm sure that most of the hospitals are not following the prophylactic antibiotic policy correctly. The first dose is can actually be given within up to 2 hours. Definitely, in many hospitals, it may not be happening. And instead of single or 2 doses, prophylactic antibiotics are given for a long time. Broad spectrum antibiotics, if it is given continuously, definitely the chances for resistance will be very high. So a clear direction as to how the prophylactic antibiotics are to be used definitely is required. Then we know that in the last 2 decades, no new molecule, no new antibiotic has been discovered. Whatever is happening is certain changes, you bring about certain changes in the existing molecule and a new drug comes in. But this cannot have definitely more antibiotics to tackle the situation. So till we have more antibiotics to tackle the situation, existing antibiotics are to be utilized very, very judiciously. So that is where the awareness program and its role comes in. Another aspect is that we have to really start thinking of health.
There's some interruption in the voice, sir.
HSG has joined.
Yeah. സാറിന്റെ നെറ്റ് കണക്ഷൻ ആണ് പ്രശ്നം. സാറാ വീഡിയോ
വീഡിയോ ഓഫ് ചെയ്തിട്ടുണ്ട്. വീഡിയോ ഓഫ് ചെയ്തു.
Animals are concerned, unless it's a concept of own health and even this use of antibiotic, this program definitely will throw a lot of light and information on antibiotic resistance.
Dr. Ravi, Matha's message is over, I think.
Over. Okay. Then thank you, sir. And
Okay, thank you. Wish you all the
Thank you, sir. Thank you very much for joining us. And now I request our Headquarters Secretary General, Dr. J.S. Lele, who is a very good friend and giving guidance to Indian Medical Association Kerala State Branch in a very beautiful way. I request Dr. J.S. Lele to address the webinar. Thank you.
Yeah, thank you, Dr. Gopi Kumar, respected past National President Dr. Marthan Pillai sir, Dr. Zakaria sir, Dr. Samuel, Dr. Devdas, and all the IMA Kerala State Branch leaders. I am very happy that this CME is organized at the Kerala State. And this was actually, as I mentioned in the CWC also, this was the launch of the antimicrobial awareness campaign with the educational grant receiving from the GSK. This is the 4th year consecutively we are doing it. Previously, we used to have a different format. This year, we had in almost 18 states, we had a simultaneously in a 1 hour a day the program. Different topics were covered, and also we had some to a central programs, one conducted from Delhi and one conducted from Mumbai for the Maharashtra. So this is a very important topic, as you will find after listening to this very day-to-day affairs, right from starting the antibiotic in our OPD practice to hospital and in ICU, different antibiotics are being used, different thinking is there by the physician. And ultimately what happens today is really definitely we need to observe that some of the antibiotics have stopped working over the period. As you recollect, when you were studying that time, chloramphenicol, tetracycline and other antibiotics were there. But now after 30-40 years, those antibiotics are not there. Similarly, last, as Dr. Marthan Pillai sir mentioned, in last 7-8 years, 10 years, probably hardly any new antibiotic has come. And over the year, day by day, the use of antibiotics is very important. So the chances are there that if you don't use it properly, if you don't use sufficiently, or if you unnecessarily use it, the antibiotic will become resistant. And the search for a newer antibiotic more and more will be difficult to get now. all the newer antibiotics, third generation cephalosporins and other things are very costly. And to have that control over the patient, control over the disease becomes day by day more and more problematic. So it is very important for all of us to understand, to understand the judicious, necessary, wherever you use it, and sufficient days so that the resistance is not developed. Last week, we had a very big program in the Mumbai, and even JSK had, and it was a world over, it was observed with a blue lighting, and like how we had in the World Diabetes Day, similar program was held at various places. So this is the culmination of the antimicrobial resistance awareness programs. So I once again thank the GSK as well as thank IMA Kerala team to organize this program. There are 8 modules in this program. For want of time, and we have not been able to send all 8 modules to you, but I will see to it that all the 8 modules are launched onto the website along with the video recording. So all the interested our CME participants can go to the website at leisure time, download if they need it, or they can listen to those very important talks, because we have got collection of almost 20 very good topics selected for the antimicrobial resistance campaign. So it will be free for all of you. So I thank once again, and I invite you to go to the IMA website and take the benefit of this entire program campaign. Thank you so much for giving me the opportunity. All the best. Happy viewing, and prescribe the antibiotics judiciously. Thank you.
Thank you. Thank you very much, sir, for attending our webinar and addressing the occasion. I think we have crammed the inaugural session into almost 32 minutes, and we'll straight away go to the CME proper. As I've already introduced the faculty, Dr. Padma Kumar and Dr. Jitin Raj. They'll be dealing with 2 topics. A few instructions to the participants. Just type down your questions in the chat box. We will have both the presentations back to back, and then after that we will have a interaction and question answer session. So by the time you type down your questions in the chat box, we will record it and we'll discuss it then later. So let me invite Dr. Padma Kumar, the first presenter. He will be presenting on decision making about antibiotic prescription. Padma Kumar, please.
Thank you, sir. Thank you, Gopi Kumar, sir, for the kind introduction. And good evening to all. Respected National President, National Secretary, and the State President, Dr. Samuel Koshi, sir, the State Secretary, Benavan, sir, and the immediate Past President, my beloved Zakaria, sir, and all other IMA co-members and my dear friends. First of all, I would like to thank especially Dr. Samuel Koshi, sir, for giving me this opportunity to present this topic in before this August audience. In fact, he has given me the presentation itself. It was prepared by the national level to keep the uniformity of the presentation. I made a little modification only in this presentation, and I would like to congratulate this national team for taking this subject as an important subject, because as we all know, during this COVID pandemic, there was widespread overuse of antibiotics all over the world. The WHO itself has highlighted this point, and especially this azithromycin. We know, even though it was not included in any of this state or national protocol, there was a widespread misuse of or overuse of this antibiotics, especially azithromycin. So I think the discussion on this topic will be very important. And let me start the presentation. Sir, please let me to share the screen, sir.
Yeah, you can. You are a co-host. You can do the sharing.
Thank you.
Yeah, okay. It's visible.
Thank you, sir. Okay. So in 1929, this miracle has happened. The first modified form of antibiotic was this penicillin was discovered by Sir Alexander Fleming, and then this discovery was an accidental thing, as we all know the history of medicine. And after the introduction of this powerful antibiotic, we all believed that we have conquered all infections widely. And after this discovery of this antibiotic, that is penicillin, there was a widespread overuse of antibiotics all over the world. Actually, we can say a misuse of these antibiotics all over the world. And following this overuse as well as the misuse of these antibiotics, the antibiotic resistance invariably happened following this misuse of this antibiotic. Actually, it was a disappointing thing that there was a antibiotic resistance, but it was quite expected also. To that extent, there was a misuse and overuse of antibiotic. So, as mentioned in this saying, you can fool all the microbes for some time. You can fool some of the microbes all the time, but you cannot fool all the microbes all the time. So this antibiotic resistance was one of the most important public health problem, as already mentioned by the all senior members. Actually, we can say that it is a silent epidemic that is widespread all over the world. So proper discussion on this topic is very important, especially in this COVID era. So coming to the definition of this antimicrobial resistance, what is actually antimicrobial resistance? By a simple definition, unresponsiveness of a microorganisms to one antimicrobial agent. That is a simple definition of antimicrobial resistance. When the microorganism is resistant to that particular drug, we can say that it is resistant, or it may be a multi-drug resistant, or it may be resistant to one drug. There are two types of antibiotic resistance. One is natural resistance. That does not pose a significant clinical problem. Some microbes have always been resistant to certain antimicrobial agents, that we know also. For example, we will not use penicillins when there is a gram-negative infection, especially when there is a urinary tract infection. We will not use penicillin because we know all the gram-negative bacilli are resistant to penicillin, so we will not use. Similarly, these aerobic organisms, again, we will not use metronidazole. It is a drug of choice, especially in anaerobic infections. Again, Mycobacterium tuberculosis, we will not use tetracycline because we know that it is a naturally resistant to that particular antibiotic. That doesn't produce any significant clinical problem. The problem is with the acquired resistance. Development of resistance by an organism which was sensitive before to an antibiotic over a period of time. Then it developed, later it developed a resistance. That is the more clinically relevant and important thing. For example, the notorious organisms which acquire the resistance over the last few decades is Staphylococcus. We know the penicillin-resistant Staphylococcus aureus, MRSA. Then coliforms, gram-negative coliforms, again is very notorious to have this multi-drug resistant. Again, multi-drug resistant tuberculosis, tubercle bacilli. Again, the national president just mentioned regarding an unfortunate incident of a cardiac thoracic surgeon also. Such things are happening. So resistance can be of a natural resistance or an acquired resistance. Acquired resistance is more clinically relevant because here we became helpless because we are unable to treat a severe infection with a particular antibiotic. Then what are the mechanisms of resistance? The most important is mutation. There is a changes in the genetic structure of the microorganism, and gene transfer also can be another thing by which this resistance is transferred from one microorganisms to another. It can be by conjugation or transduction or transformation. There are many methods by which antibiotic resistance can be transferred from one microorganisms to another microorganism. So this is the background of this today's presentation. Now we have to discuss how to make a proper decision while we are selecting an antibiotic and while we are prescribing an antibiotic. Which are the factors that affect the antibiotic formulation? One of the most important factors is genetic factors such as lack of B6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. As we all know, it is an enzyme that can produce severe hemolysis in a certain group of persons, especially when there is an antibiotic is given or when a particular drug is given. The drugs which are notorious to produce hemolysis in G6PD deficiency individuals includes these fluoroquinolones, which are widely used in urinary tract infection or gram-neck infection, and then there is nitrofurantoid-like drugs. All these can produce the G6PD hemolysis in G6PD deficiency, which is very common in Southeast Asian population. Then again, factor which was affecting an antibiotic formulation is whether there is a renal or hepatic impairment. Definitely, we will not use this aminoglycosides or vancomycin when there is a renal impairment, and we will not use this tetracycline or macrolide antibiotics like azithromycin when there is a hepatic impairment. So all these factors we should consider while selecting an antibiotic. Then bactericidal drugs are necessary for life-threatening infections such as sepsis. When there is a very severe infection like sepsis, multi-organ damage, definitely we have to select a bactericidal drug. These bacteriostatic drugs like tetracycline or erythromycin will not be useful in that condition. Before the administration of antibiotics, if possible, we should send both aerobic as well as anaerobic cultures, especially when the infection is severe. That also is another important thing which we have to consider while selecting an antibiotic. In life-threatening infections, the administration of antibiotics should be immediate, based on the local sensitivity pattern. We should not wait for the culture.
More.
Screen is there, voice is not heard.
Yeah, there is net issues. Probably is.
Is he muted or?
Stop his video, and I think Patmova can speak by stopping video.
No, he cannot stop because he is sharing the screen. No?
Oh, that's right.
Cannot stop that.
Ah,
And probably he has very little.
ban
The net range. I think he has lost connection. He has to rejoin. He has lost connection. I'll be joining shortly. He has lost connection.
We have called him.
Yeah, he is joining.
He has joined.
Yeah. Yes.
sorry for the interruption. There is some net problem here. Sorry. Okay, now coming to the strategy of this antibiotic prescriptions. Govimar sir, am I audible?
Yeah, audible and clearly seen. Okay.
Oh, thank you, sir. Thank you very much. So the strategy of the antibiotic prescriptions, patients who develop an infection during their hospital stay, that is an hospital-acquired infection, empiric antimicrobial therapy administration should take account of the sensitivity of the flora. We have to consider the local sensitivity and specificity of that particular institution before we are selecting an antibiotic. So we can seek the advice of this microbiology department also. The remarkable ability of the microorganism to adapt to any environment is that each new pathogen is resistant to antibiotics administered in the previous period. So once an organism resistance is shown to have some resistance, we should know that it might have acquired the resistance during the previous hospital admission or the previous hospital stay. Patients with meningitis should be administered antibiotics, which should not be administered antibiotics, which should not pass the blood-brain barrier as the first generation cephalosporins or gentamicin or clindamycin. We are using these penicillins or third generation cephalosporins when there is a bacterial infection, that is meningoencephalitis, which can easily cross the blood-brain barrier. We will never use antibiotics which are not crossing the blood-brain barrier, such as the first generation cephalosporins or gentamicin or clindamycin. In endocarditis, the treatment should be done with bactericidal drugs because it is a powerful infection. So we have to select an antibiotic which is powerful. We should not use a bacteriostatic drug when the infection is severe. So to summarize, when we are treating an hospital-acquired infection, definitely we should get the sensitivity pattern from the microbiology department. And severe infection, we should treat immediately. And if possible, we should consider the antibiotic sensitivity pattern, and definitely severe infection should be treated with bactericidal drugs. Then foreign body infections, especially prosthetic valves as well as prosthetic joints, it is almost impossible to eradicate the infection without removing the foreign body. That is a well-known fact. In acute infection, patients with neutropenia have an increased mortality from sepsis. And appropriate direct intravenous therapy with broad-spectrum bactericidal antibiotics at high doses, that should be our aim. We should use broad-spectrum antibiotics when there is a neutropenia. And older people, that is a very important thing, especially in geriatric population where the blood circulation is impaired, their gastric motility is impaired, so the absorption of the drugs is also impaired. Then we should select the antibiotic in such a way that the dosage should be adequate, as well as the interval between the doses also should be adequate, especially in elderly population. At this age, drugs with the greater renal toxicity such as aminoglycosides, we should not use. This is regarding the elderly population. Now, regarding this management of antibiotics by health professionals, too many antibiotics together may act synergistically, especially we know bactericidal drugs. For example, penicillin we can combine with this aminoglycosides we can combine, or bacteriostatic drugs we can combine. The classical example is sulfamethoxazole with trimethoprim we can combine because they act synergistically. The majority of infections, but we can treat with a single antibiotic. But there are cases where it is necessary to combine the administration of antibiotics where we are getting a polymicrobial infection. For example, in patients with brain abscess or infections of the lower limb with cellulitis, in such conditions, we can combine antibiotics. But always we have to remember that only bactericidal drugs can be combined together, or bacteriostatic drugs can be combined together, but never in the reverse direction. That is, a bactericidal drug with a bacteriostatic drug, we will never combine in such severe infection. Then again, the use of many antibiotics results in more side effects, as we know. Adverse reactions to antibiotics are common and are divided into idiosyncratic reaction, which is not a dose-dependent one, allergic reactions, and also dose-dependent reactions. When a patient taking many antibiotics had an allergic reaction, then all antibiotics are suspect and cannot reuse. For example, if you are using both penicillin as well as aminoglycosides, and a particular person develops an allergic reaction, then we had to suspect both as the predisposing factor for the allergic reaction, and we had to stop it. The use of many antibiotics increases the infection of antibiotic-resistant microorganisms. The destruction of that is another important point. The destruction of the flora of the oropharynx and gastrointestinal tract We have normal commensals in the oropharynx as well as gastrointestinal tract. That is very important, and that can produce again the development of multi-drug resistant microorganisms. So the destruction of the normal flora in the oral cavity as well as the gastrointestinal tract also can produce development of resistant microorganisms. But all this shows that overuse as well as inadvertent use of antibiotics definitely we have to avoid. Then coming to the overuse of overuse of antibiotics, antimicrobial overuse is the major healthcare issue that contributes to the antibiotic resistance. Such overuse includes unnecessarily long duration of antibiotic therapy. That is the point which I am going to highlight. Unnecessarily long duration of antibiotics is not a scientific thing. In patients with common viral infections such as acute bronchitis, in patients with COPD exacerbation, or patients with community acquired pneumonia, or urinary tract infection, cellulitis, etc. The overuse of antibiotics in that particular way, that is, we are using antibiotic for a long period. That also is another way by which we are promoting the development of antibiotic resistance. For example, when should antibiotics be prescribed and limitations of antibiotics treatment in various cases? We are discussing a few cases. Clinicians should limit antibiotic treatment duration to 5 days when we are managing patients with the COPD exacerbations and acute uncomplicated bronchitis with some clinical signs of bacterial infection. So patients with the COPD acute exacerbation, one of the most common cause for exacerbation is a bacterial infection, we know. In such conditions, prolonged use of antibiotics we have to avoid, and as per the direction, the 5 days antibiotics is sufficient to control the infection in such clinical situation. A clinician should prescribe antibiotics for community acquired pneumonia for a minimum of 5 days. Here the thing is different. Here we had to use antibiotic at least for a minimum period of 5 days, and maybe up to 5 to 10 days we had to use antibiotic when there is a pneumonia is occurring. Extension of the therapy after 5 days of antibiotics should be guided by various measures of clinical stability, which include resolution of the vital sign abnormality, then ability to eat, as well as normal mentation, general condition of the patient. So continuation of the antibiotics beyond 5 days is mainly based on the clinical status of the patient or the clinical improvement of the patient. For mild infections like acute bacterial infection, which produces an exacerbation of the COPD, antibiotic therapy for at least 5 days is sufficient as per this direction. In women with uncomplicated bacterial cystitis, short course of antibiotics, either nitrofurantoin for 5 days or trimethoprim sulfamethoxazole combination for 3 days, or fosfomycin as a single dose is sufficient in uncomplicated bacterial cystitis. In men and women with uncomplicated pyelonephritis, then short course therapy either with a fluoroquinolone for 5 to 7 days or sulfamethoxazole trimethoprim for 14 days is necessary or sufficient based on the antibiotic susceptibility. So in summary, unnecessarily prolonged use of antibiotics in such mild infections or uncomplicated infections, again, we are promoting the development of drug resistance. Most of the time, 5 days antibiotic course is sufficient in mild infections, and up to 14 days is necessary when there is a infection like pyelonephritis. In patients with a non-purulent cellulitis, clinicians should use a 5 to 6 days course of antibiotics active against streptococci, like penicillin we had to use. And this is another pictorial representation of various aspects which we are now discussing. Every time antibiotics are prescribed, we have to remember that order recommended cultures before antibiotics are given and start drugs promptly. That is already we have mentioned, if possible, both aerobic as well as anaerobic culture we have to do. Make sure regarding the indication, dose and expected duration are specified in the patient record. That is also very important, because when we are starting an antibiotic, when we are changing the antibiotic, or when we are stopping an antibiotic, all this should be properly and neatly recorded in the case sheet. Otherwise, another another medical officer who is looking into the case sheet or may not get an idea, and again, a prolonged antibiotic therapy may be continued. Such things we had to avoid by proper recording of the dates. Reassess within 48 hours and adjust the treatment if necessary, or stop treatment if indicated. For example, a patient, we send the culture and sensitivity, and we have already started an empirical antibiotic, but after the culture and sensitivity result is against this antibiotic, or it is found to be resistant, then we have to change the antibiotic. So reassessment of the patient after 48 hours is also very important. Now coming to the points which we just mentioned, treatment for urinary tract infections, make sure that culture results are represent the true infection and not just colonization. A patient should be symptomatic also. Assess patient for signs and symptoms of UTI. Just a presence of pus cells in the urine is not a necessity or not an indication for starting antibiotics in urinary tract infection. Make sure that urine analysis is obtained with every urine culture. Treat for recommended length of time. We have seen already 5 to 7 days is sufficient. And ensure that planned post-discharge treatment takes into account the antibiotics given in the hospital. Treatment for pneumonia, make sure that symptoms truly represent pneumonia and not an alternate non-infectious diagnosis. If it is a viral pneumonia, again, there is no indication for antibiotics. Treat for the recommended length of time and ensure that planned post-discharge treatment takes into account the antibiotics given in the hospital. When we are converting an IV drug to oral drug, again, the same class of drug, if it is a third generation cephalosporin, then we have to convert it into either cefixime or a first generation cephalosporin while we are discharging this patient. Such things we have to monitor. Treatment of this methicillin resistant staphylococcal organisms. Again, verify that this MRSA is growing in clinically relevant cultures. Do not use vancomycin because it is again a powerful antibiotic which can produce various side effects. If it is to treat infections caused by methicillin susceptible staphylococcus and not MRSA. MRSA is a very notorious organism which is producing very severe infections, which is very difficult to treat also. In such conditions, we may require vancomycin or other powerful antibiotics like this linezolid. Otherwise, this usual drug is sufficient in methicillin is sufficient in methicillin susceptible staphylococcal aureus infection. Again, the same thing in another pictorial representation. Overuse of antibiotics is leading to resistance. The pill popping syndrome we have to avoid. The commonly used antibiotics which are misused also, erythromycin, azithromycin, amoxicillin, cifran, or ofloxacin. And the common conditions where they are taken for is fever, common cold, cough, sore throat, diarrhea, etc. Antibiotics should be prescribed in optimal doses, regimens, and stopped when infection is treated. And clinicians should be familiar with local antibiotic sensitivity pattern. Hospital antibiotic policy should be formulated based on local antibiotic resistant data. All these points we will discuss in the coming slides. Then coming to the general antimicrobial prescribing advice. Do not start antimicrobials in the absence of clinical evidence of bacterial infection. Very important. Only when the patient is having evidence of bacterial infection in the form of purulent nasal discharge or purulent expectoration or prolonged fever or we are getting culture sensitivity result or a blood examination showing a polymorphonuclear leukocytosis. In such conditions, we have to start antibiotic. Initiate prompt treatment with effective antimicrobials for sepsis and life-threatening infections as soon as possible, and always within, if possible, within 1 hour of presentation, because we should not wait for the cultural sensitivity result. In life-threatening infections, empirical treatment we can start. Use antimicrobials with an adequate spectrum of cover for the likely pathogen for less severe infections. In less severe infections, the likely pathogen we can consider based on the local sensitivity pattern also, we can select the proper antibiotic also. Ensure that the appropriate specimens are taken for culture and sensitivity testing prior to commencing an antibiotic treatment without delay in starting treatment in severe sepsis or life-threatening infection already mentioned. Consider IV administration only to patients who are severely ill, unable to tolerate oral treatment, or where oral therapy would not provide adequate coverage or tissue penetration, example, CNS infection. So IV antibiotic, the proper selection is very important. Only when there is a severe infection, we have to consider IV antibiotics. Consider switching IV antibiotic to oral route of administration promptly according to the local switch policy. When we are discharging the patient, we can convert the IV antibiotic to oral antibiotic as per the discharge policy. Document the next review and the stop date on the prescription. As already mentioned, documentation is very important. It is essential to review antimicrobial prescription after 40 to 72 hours. Again, we mentioned the importance because sometimes the cultural sensitivity may not be favorable to that particular antibiotic. Then we had to change it. And we have always should clinically review and checking microbial results. We have to change if necessary. A clear plan should be there and documented in the case notes, which should include when to stop an antibiotic. IV to oral switch also has to be written in the case sheet. Change of the antibiotic again has to be properly recorded. Continue and review, that also have to be recorded. Then outpatient parenteral antibiotic therapy. If we are planning a parenteral therapy as an outpatient basis, all these things should be recorded properly in the case sheet. And another important point which we are going to discuss is antimicrobial stewardship. That is a very important point regarding the selection and the proper use of antibiotic to prevent the antibiotic resistance. How to start a proper stewardship? Do not start antibiotics in the absence of clinical evidence of bacterial infection, a simple viral infection or a simple common cold. Again, there is no need of any antibiotics. Take thorough drug allergy strategy. Initiate prompt effective antibiotic treatment within 1 hour of diagnosis in patients with a severe sepsis or life-threatening infection, already mentioned. Comply with the local antimicrobial prescribing guidance. Document the clinical indication, dose, and route on drug chart and in clinical notes, especially for the juniors. The proper documentation of the introduction of an antibiotic, when we are changing the antibiotic, when we are stopping it, everything is very important. Include review or stop or date of continuation or duration of the antibiotic, and the culture and sensitivity results also we have to record properly. Then clinical review after 48 to 72 hours. Then again in the clinical review as well as in the documentation, we had to document stop, IV oral switch, change of antibiotic, continue, as well as oral parenteral antibiotic treatment. All the points are mentioned, but these are all important in the antibiotic stewardship program. Antibiotics do not work for everything. That is another important thing which we had to highlight. They are not the drugs for fever. ആന്റിബയോട്ടിക് മരുന്നുകൾ എന്ന് പറയുന്നത് പനി മരുന്നുകളല്ല എന്നുള്ളൊരു മെസ്സേജ് തീർച്ചയായിട്ടും നമ്മൾ കമ്മ്യൂണിറ്റിയിൽ കൊടുക്കേണ്ടതുണ്ട്. ആന്റിബയോട്ടിക് മരുന്നുകൾ എന്ന് പറയുന്നത് ജീവൻ രക്ഷാ ഉപാധികളാണ്, അവ വെറും പനി മരുന്നുകളല്ല എന്നുള്ളൊരു മെസ്സേജ് വി ഹാവ് ടു ഗീവ്. ആന്റിബയോട്ടിക്സ് ഡോണ്ട് വർക്ക് ഫോർ colds or flu, vomiting, most of the coughs, most of the ear infections, sore throats. In such mild infections, antibiotics are not at all necessary, but they are necessary in various severe infections like pneumonia, sepsis, or sore throat. In severe infections, they may be necessary. Then again, the instructions to follow while prescribing an antibiotic. The prescription of antibiotics is not necessary in every condition. The antibiotics to viral infection do not reduce the duration of the symptoms or protect people around you. That also we had to highlight that point. You would strictly adhere to the instructions and durations of the antibiotic treatment. This is mainly to the patient population. Follow these physicians' instructions carefully in the selection of antibiotics. It is a common habit of these patients to stop antibiotic before the course is completed while their symptoms are relieved. So that is again another important factor which can produce a drug-resistant organism. So such things we had to properly educate this patient. What should physicians do to reduce the inappropriate use of antibiotics? What is our role? Physicians will have to balance the risk of not treating or inadequately treating against the risk of antibiotic use. Regarding adverse effects, drug interaction, and antibiotic resistance, we have to consider which is the risk-benefit aspect. Whether treating this that particular infection is giving benefit or risk, that we have to consider. From a clinical perspective, many providers may not be highly concerned of their antibiotic prescribing habits, since many patients expect to get an antibiotic when they visit a physician for an issue they perceive as bacterial, because it is especially in our Kerala people, they are always in need of more and more drugs in our prescription. So it is their expectation to have an antibiotic also. So such habits or such beliefs we had to modify or we had to change by proper education. A didactic educational discussion with the patient is necessary to change our over-prescribing phenomenon. Patients should be educated on the viral etiology of different infectious syndromes in which antibiotics are unnecessary. We should educate them. All the infections are not bacterial. It can be simple viral also where antibiotics are not necessary. The prescription of antibiotics in these circumstances is futile. It exposes the patient to undesirable side effects or drug-drug interactions and increase the healthcare cost as well as possibility of developing an antibiotic resistance. So how to prevent the resistance? We are coming to the end of our presentation. So what are the measures by which we can prevent the drug resistance? Send appropriate samples for investigation and target the pathogen. That is the most important aspect. If there are facilities and if you have the proper microbiology department, when there is a multidisciplinary facilities are available, definitely we should select the proper antibiotic after the culture and sensitivity result. That is the first thing. Treat the infecting organism and not the contaminant or colonizer. That is again another important thing. Ensure that the patient meets the criteria for infection before going ahead with unnecessary antibiotic treatment. That is also very important. Daily check on the devices, because especially critically ill patients may be having many devices like a catheter or a rice tube, etc. Any device inserted in a patient is a nidus for infection. The bacterial film is formed that will prevent the entrance of the antibiotic also. Clinicians need to do a daily check on the devices inserted in the patient and their ongoing need also. As early as possible, we had to remove that device if possible. Any device that is not in use should be promptly removed, especially the problem with this catheter we had to remember. Access the experts. It is not realistic to expect a general physician or surgeon to keep up to date regarding all the developments in the field of infectious diseases. Hence, they need an access to an infectious disease specialist, especially in the field of infection at the earliest. That is also another important aspect. And if possible, vaccinate. This use of antibiotics can be prevented or can be reduced by proper vaccination of many of these infections. Pneumococcal
Again, the voice is gone, right?
Net slow. We lost connection.
We are rejoined now.
നമ്മുടെ കിരണാണോ?
Sir, he is back. He is back.
ഡൽഹിയിൽ നിന്നാണ്, നമ്മുടെ അല്ല.
So coming to the last few slides regarding this antimicrobial stewardship. Antimicrobial stewardship is the ongoing effort by a healthcare institution to optimize antimicrobial use among the hospitalized patients, to improve these patient outcomes, to ensure the cost-effective therapy, and to reduce the adverse sequelae to antimicrobial use. This terminology is nowadays very popular thing, antimicrobial stewardship. Educating clinicians is of paramount importance, which we are just now doing as per the IMA direction, as they need to understand the prescribing of antibiotic to a patient does not only affect the patient's benefit, but can produce some changes in the bacterial flora of the hospital also. Formulary restriction is a method of restricting the use of high-end antibiotic use, such that they can only be prescribed post-authorization by an infectious specialist. So in certain hospitals, such a formulary direction is there. If they are planning to or they want to use a high antibiotic, they should get a permission from the infectious disease department. So such control also can be tried as a part of stewardship. The program needs to be spearheaded by a multidisciplinary team consisting of a microbiologist, infectious disease specialist, and an antibiotic pharmacist group, which can audit the use of antibiotics, perform surveillance as well as resistance studies also. Dose optimization, de-escalation, changing the route of administration of antibiotic, intravenous to oral, all have to be done in a timely manner as per this stewardship program of that institution. So to summarize, These are few instructions to the patients while to prevent or reduce the chance of developing drug resistance. Wash your hands. Our bodies are constantly exposed to millions of germs. Regular hand washing can help fight germs or prevent illness. We know that during this COVID era. Know your symptoms. Learn how to recognize early symptoms of an infection. If you think you have an infection or if your infection is not getting better, then only get the advice from a health professional. Ask questions regarding the antibiotic usage to the health practitioners. Learn the right way to use antibiotics. You have to use the proper antibiotic at the proper time, and also the proper dosage, proper course of the antibiotic. Never share or use leftover antibiotics. Using the same prescription, many persons are using the drug. That should not be, it's not a scientific thing. Prepare food safely. That is also another important aspect, because we know this broiler chicken. In many of these broiler farms, they are using these antibiotics to prevent infection to this chicken, and the consumption of such chicken, even though it is in a micro quantity for a long period, can produce the chance of developing drug resistance. Get vaccinated if possible. And again, the pictorial representation of the same thing. And regarding this, physicians prescribe antibiotics, practitioners prescribe antibiotics carefully. That is very important. Make sure to stay up to date on the recommended antibiotic practices and doses. And also, we have to be updated regarding the antibiotic knowledge. Education of your patients is also very important. Wash your hands, because while we are examining many patients, we may be transferring this microorganism, drug-resistant microorganism from one person to another. So washing our hands itself is very important. Get vaccinated again, because the transmission of infection from our side to the patient should not happen. And take the antibiotic stewardship pledge. That also we already mentioned. Every hospital should have a policy to have a proper stewardship program for the judicious use of antibiotics to prevent the development of antibiotic resistance. And that is all regarding antibiotic resistance and the proper and judicious use of antibiotics to prevent the development of antibiotic resistance. Thank you, sir. Thank you very much.
Thank you, Dr. Patmawar, for that exhaustive but very lucid presentation on the proper use of decision making about antibiotics. Okay, straight away we'll go to the second presentation by Dr. Jitin Raj, who is Assistant Professor of Medicine in TD Medical College, Alappuzha. He'll be dealing with a few interesting cases. Dr. Jitin Raj, over to you, please. Jitin?
Yeah, already joined, sir. Already joined.
Yeah, he is there.
Yeah.
I think the net is a little weak.
Okay.
Jitin?
Okay, sir.
Yeah.
Okay. Now
Okay. Can you share this slide, please?
So we see the co-host now.
Jitin along. Jitin disconnect. Okay. Co-host, right. Jitin is a co-host. You can share the slides.
Yeah, sir.
Allah, he is there.
Hello.
Yeah. Visible. Now you are audible, Jitin. Yeah.
Okay, sir.
Yeah. Now you can.
So.
Yeah. Okay.
almost all of the important topics are covered by our respect. Now I am going to a few interesting cases. That's
Your voice is
not
getting
clinical
better.
cases.
Within your voice is getting
Yeah, Jitin, your net is very
feeble.
feeble net. Voice is breaking, and you're not seeing the video also. Yeah, okay, he's rejoining. Yes.
Okay. He's joining from Vandanam, sir. Vandanam. He's staying in Vandanam.
Vandanam,
Yeah.
range may be less.
Yeah, right. There is some difficulty in. So you must well know the geography of Vandanam.
Yeah, okay, yes.
Yeah.
Right. Now we are visible. You are audible also.
Thank you. Okay. So a few interesting cases from the literature I'm dealing about. But before that, just an introduction. Already told antibiotics, and these antibiotics are the most successful drugs ever developed by the humankind. And but soon after their discovery, the bacteria became resistant to them. Actually, there was evidence that these bacteria can be resistant to them just after the discovery of the antibiotics itself. And for some decades, there was a golden period from this period. There was a multiple antibiotics which are coming through the pipeline. But now this is not happening. So for some decades, the problem was actually alleviated by the constant introduction of the new antibiotics. Actually, this was the timeline. And in 1928, the penicillin was discovered. And 1950 to 1960, actually, it was the golden age of the antibiotics. And here in 1940 itself, initial penicillin resistance was identified. And in 1960, around 1960 and 1961, the first MRSA was detected. So even in the early phase of the antibiotic development, the resistance itself identified. And now we can see that from the 1970 onwards, in each decade, actually 2 or 3 antibiotics are only coming. And not like the golden age, there are more than 10 antibiotics came in each decade. So actually there is a crisis period now. We are dealing with less and less number of sensitive antibiotic to the bacteria. And actually this increase in the antibiotic resistance can impact humans. Mainly 2 scenarios are there. First one is the direct effect on treating the infections, because we know that all these resistant infections, it is very difficult to treat, and they may lead to the death of the patient. And also the compromising the treatments that require the immunosuppression, intubation, and catheterization, and advanced surgical procedures and chemotherapy, because these antibiotic resistance will produce these patients more susceptible to the development of infections after these procedures and chemotherapy. So it will be very difficult for our clinicians to determine the proper dose of this immunosuppression and chemotherapy with these patients. So actually they are affecting in these 2 methods. And this unnecessarily use or misuse of the antibiotics, and more than that, inappropriate prescribing patterns and the lack of new novel antibiotics finally leads to the antimicrobial resistant pathologies. Actually, this is the antimicrobial resistance and not the antibiotic resistance. Now, the antimicrobials handle with care. That is the motto of the WHO. That means the antimicrobials should be handled with very care, like that we are dealing with a glass or something like that. And this already discussed, origin of the antibiotic resistance. Actually, this is an adaptive trait, not an inborn trait. Is we are discussing. Inborn means already said that some bacteria will be resistant to some of the antibiotics inherently. But mainly this antibiotic resistance in a clinical setting, it is an adaptive trait. And after challenging with the therapeutic antibiotic dose, only these patients will develop this antibiotic resistance. And main 2 processes leading to this antibiotic resistance include the mutation and horizontal gene transfer. And this is the summary of this. This means that there are some clinical implications for this antibiotic resistance or antimicrobial resistance. They will hinder the effective treatment. They will deplete the success of the chemotherapy for cancer therapy or organ transplantation. and even minor dental surgeries would be compromised. And also they will prolong the treatment and expense of the drugs, and finally leads to the financial burden for these patients. And they will finally lead to the permanent disability or even death to the patients, even with the very common diseases produced by these resistant organisms. So coming to the interesting cases from the literature, we are going through the first case. In this case, actually, this is treating a rare mixed infection with a sensitive antibiotic. Here, actually, this is a case report from Japan. It was a 37-year-old man who had fallen out twinning his left fingers in a row. It was happened in 2001. And his left, second and third digits were amputated by this method. And these amputated digits were exposed to the lake water for several minutes to hours. And after that, he was taken directly to the hospital and admitted there. At the admission, his CRP was normal, and the total count and platelet was almost normal. Total count was slightly increased. Initially, he was treated surgically with replantation and stem plasty. And after that, as usual, the cefazolin 2 gram administered twice daily for the antibiotic coverage. But after sometimes it was noted that his replanted fingers had necrosis, and after there was wound infection. On the 12th day in hospital, his fingers were removed. And in that, there was cultures from the wound fluid, which showed that there was growth of the Aeromonas hydrophila and the Vibrio alginolaticus. Actually, it may from the lake, from the saltwater lake. And due to these resistant organisms, the antibiotic therapy, which was changed to the IV imipenem, 0.5 gram BD, and his laboratory examinations all were repeated, and it was shown that this CRP was markedly increased. And the minimum inhibitory concentrations were determined by the agar dilution method, and susceptibility test was also done. And this Aeromonas hydrophila, it was shown that it was MIC was very high for ampicillin and cephaloridin, so it cannot be given. And it was in the moderate side, between 1 to 4 milligram per liter for the carbapenems, like the imipenem, panipenem, and meropenem. And it was very low, and it was highly sensitive for ceftazidime and aztreonam. And the Vibrio alginolaticus, high MIC for ampicillin. And both these isolates were susceptible to these ceftazidime, aztreonam, imipenem, meropenem, levofloxacin, and minocycline. And here the mechanisms of the beta-lactam resistance in the this Aeromonas hydrophilia is that it actually had at least 3 types of beta-lactamase genes. The class B metallolactamase genes were there, and class D beta-lactamase gene was there. And so by these methods, it became resistant. But in the case of Vibrio alginolaticus, it was found that it had there was a production of beta-lactamase. More than that, it had some cytotoxicity also. And it was having some cytotoxicity up to dilution of 1:16 and 1:4 against the HeLa 688 and Hep2 cells respectively. So by both these methods, the antibiotic resistance and cytotoxicity, this Vibrio alginolaticus was dangerous. And this antibiotic therapy was changed from cefazolin to the imipenem, 0.5 gram BD for 14 days, and the wound infection was resolved. So it was a direct case of treatment of a mixed infection of 2 uncommon pathogens with a single agent. That means only IV imipenem was needed for both these infections, and it was completely resolved, wound infection. And so this was the first case. But the second case, it was a little different. Actually, this is a rare case, which was actually treated in a hospital in Spain. And this case was reported from the Spain. And this is a case of a change in antibiotic sensitivity while the patient is on treatment with an antibiotic. Here it is a 39-year-old man, and he was a case of craniopharyngioma, and previously surgical resection was done. And he was admitted with symptoms of acute hydrocephalus, and he was managed with external ventricular CSF decompression. On the 8th day following the procedure, he had presented with CSF leakage at the surgical wound. And on the day 11, it was obviously a turbid and xanthochromic CSF, highly suggestive of his CSF infection. And so the CS of study was done, which was very high in cells, like 5,360 cells, almost 98% of neutrophils. So obviously, acute meningitis was there, and the glucose was very low. So, as usual, the vancomycin was started along with meropenem, but the CSF isolate was actually Acinetobacter baumannii, and it's a highly drug-resistant organism. And the susceptibility and resistance tests were done. Susceptibility test showed that the organism was susceptible to multiple drugs, like especially colistin, also to the tigecycline, amikacin, gentamicin, and tobramycin. But initially, it was resistant to most of the drugs, including cefepime. And on the day 14, the vancomycin and meropenem discontinued according to the results from this culture, and the colistin was started. In high dose, the colistin was started. And on the day 23, again the CSF were remained similar. It was xanthochromic and it was turbid. Again, the same organism, Acinetobacter baumannii, was isolated. But at this time, it was noted that this organisms, even though it was susceptible to all other agents previously susceptible, but it was resistant to the colistin. And at that time, it was also resistant to the cefepime. So at this point of time, even though the colistin was not stopped, they also added the intrathecal gentamicin 10 milligram 12th hourly to this regimen. And later on the 28th day, again the CSF was not improving. It was turbid and xanthochromic, but the cell count was improving. Previously, it was more than 5,000. Now it is only 980 cells per microliter, which was 100% neutrophils, and the glucose level was very low. Again, the same organism, Acinetobacter baumannii, was isolated, but surprisingly, here the sensitivity pattern was changed. Previously, it was sensitive to colistin and resistant to cefepime, but now this organism is susceptible to cefepime and resistant to colistin. So, initial resistant and sensitivity pattern of this same organism, while on treatment with the colistin, has changed to the opposite side, and the cefepime now became sensitive. And on the day 31, the ventricular drainage was discontinued. And on day 34, the patient was actually, along with this colistin, even though they stopped gentamicin, they added cefepime and sulbactam. And on the day 57, the CSF became improving, and only 54 cells with 100% neutrophils, and the glucose level was also increasing. That is a good sign. And the antimicrobial treatment, they could stop by the day of 66, and the patient was able to discharge without any clinical signs of infection. So this case report confirmed that there may be a chance of the development of a resistant organism while the patient is on treatment with a previously sensitive antibiotic. Here it is the colistin resistance of this Acinetobacter baumannii that was selected in vivo inside the body of the patient while the patient was on colistin. So it was postulated that it may be due to a subgroup of these organisms, like the Acinetobacter baumannii, which was initially itself resistant to the colistin, but may became overgrown by the constant supply of the colistin to the body, and the lack of the other agents, which was already killed by this colistin. All the colistin sensitive Acinetobacter was killed by the colistin, and only the resistant organism became more and more proliferating and became the main organism. And that organism was all sensitive to cefepime. So another, that means the acquisition of a resistance to this colistin in Acinetobacter baumannii in this case led to the change in the antibiotic resistance profile also, because the initially resistant cefepime became susceptible. So the total change in the susceptibility pattern. So the key point is that the antibiotic sensitivity pattern may change even while the patient is on treatment. Sometimes the previously resistant antibiotics may later become sensitive. And so we should recheck the sensitivity pattern if the patient is not responding to the treatment properly, even though patient is on the drug which is previously was sensitive for the organisms. Because there may be some subgroup of the organisms which may overgrown later due to the supply of this antibiotic, and that may be sensitive to some other antibiotics and may be resistant to this antibiotic which we are giving now. And next is another case report that is actually from Israel, and which is studied in collaboration with Oxford University. This is a newer method in which almost disease which is not responding to most of the antibiotics which was treated with a newer therapy, that means the bacteriophage therapy, along with high-end sensitive antibiotics. So what is bacteriophage? Actually, this bacteriophage, we know that it's a virus which is affecting the bacteria and which has a capsid, a head, and inside that there is DNA, neck is there, collar is there, multiple whiskers from this neck, and there is a sheath with a base plate and spikes from this base plate, and tail fibers are there. And using these tail fibers and base plate, this organism is getting attached to the bacteria and invading the bacteria. Actually, these bacteriophages are the most ubiquitous viruses in this world, and they are seen in almost every object in this world. And so, but there is specificity. Almost a single type of bacteriophage will affect only a specific number of bacteria, or it may affect a single type of bacteria only. So this is the picture in which we can see that this bacteriophage is attached to the bacteria and trying to invade it. And there is some advantage of this bacteriophage therapy. Actually, this is a newer therapy, and there is a definite specificity of the action, because we know that this bacteriophage is specific for a bacteria and the very narrow spectrum of activity, because it is not going to affect any other bacteria, and any other disease will not be modified, or we can treat other diseases as usual. And the safety is very high because this organism cannot affect humans normally. And the tolerability is also high. The administration is very easy, like that of the antibiotic. We can give it IV, or we can give it locally through the bowel or through the bladder irrigation. We can give this organism. And the effect is limited to the site of infection, because this bacteriophage will not go to any other site infecting other cells. Only the bacteria will be affected. And the possible other additional benefit we can get by genetic engineering of these organisms, and less expensive compared to other newer antibiotics and other newer therapies. And these are some of the studies in which they show some promising effects of these bacteriophages in the treatment of human infections. But there are some limitations also, but coming to the advantages, these are very limited. Actually, the main problem is that means there is absence of a specific activity in a given bacterial strain, because sometimes it may affect, sometimes it may not affect. Unlike the antibiotics, which may affect all the susceptible organisms, this bacteriophage may not always affect the bacterial strain. So there is not such specific activity, but most of the time it will affect. And second one is more important. That means when we are administering this bacteriophage, there may be chance of some phage encoded toxins or genes or other bacterial virulent factors which can get into our body and may produce some unwanted side effects. That's the side effect by these factors, not the bacteriophage itself. And the formulation and stabilization of these preparations are difficult, and newer methods should be found out for that. And possible emergencies there. Even against this bacteriophages, the bacteria can get resistance. And these bacteriophages can again develop, lead to the development of antibiotic resistance. And our immune system will definitely act against this bacteriophage because it's a newer antigen to our body, naive antigen. So it will definitely act against our bacteriophage, our immune system, and will reduce its activity. And as I said earlier, this is very specific, only replicate at the site of infection. No serious side effect has been described. And this phage-resistant bacteria remains susceptible to other phages having a similar target range. And most important one is that even there may be a chance of resistance against these phages, but we can find out their alternate phage relatively rapidly than a newer antibiotic, because these bacteriophages are ubiquitous organisms, and we can relatively rapidly find out a newer bacteriophage which can act against the resistant organism also, unlike a antibiotic in which the development of a newer antibiotic is very time consuming and it takes several years. And this is the spot test used for the phages. This clearing, like the antibiotic sensitivity test, the clearing inside a bacterial inoculum shows that it is susceptible to this phage. This is known as the phage spot test. So in our third case, it is the bacteriophage therapy along with this high-end sensitive antibiotics. This is a 48-year-old gentleman who was admitted to the trauma unit after a motor vehicle accident. And there was bilateral grade 3 open fractures of both extremities, both lower extremities. Left side, it was a bicondylar tibial fracture, and right side was a distal femoral fracture. And he was initially treated with external fixation and other treatment. Later, it was converted to internal fixation. And 9 days after his admission, there was an infection of his right side proximal tibia was noted. It was a multi-drug resistant Klebsiella pneumonia. And this was isolated from the wound. And again, after that, 6 weeks after the admission, extremely drug resistant Acinetobacter baumannii was also isolated from the wound from his left tibia. So here also he was infected with multi-drug resistant Klebsiella pneumonia and extremely drug resistant Acinetobacter baumannii. And serial irrigations and debridement was done. Underwent a cement spacer placement due to bone loss. And again, he was treated with multiple drugs like piperacillin tazobactam for the initial 6 weeks, followed by meropenem and high-dose colistin, an 8-week course. But actually, he was not improving, and his wound broke down. And around this stage, after around 6 months was passed, and he was advised to have an eboiny amputation, but the patient refused. So he was enrolled for the phage therapy as the last resort. Here, a few words about the phage. Actually, this was a combination of phages we are usually giving. And here also we are giving this combination because there was 2 organisms in these patients, and the Acinetobacter baumannii and the Klebsiella pneumonia. So the phages against this Acinetobacter baumannii and also Klebsiella pneumonia was given. Along with that, the IV meropenem and colistin was also continued because in the in vitro sensitivity studies, they were sensitive. And here they administered 1 ml of each phage as an IV thrice daily over 35 minutes for 5 days. And this is an endotoxin concentration, means this is a property of the phage, and that should be less than 5 endotoxin units per kilogram per day. So it was less than that, 35 for the Klebsiella phage and 5 for the Acinetobacter phage per ml. And first 3 doses were given in ICU, but there was no side effects. So patient was shifted to the ward and given the rest of the treatment. But after the first therapy, that means 5 days of therapy, the isolated of, materials from the wound was showing again the growth of Acinetobacter baumannii. So again, a second treatment course was given for an additional 6 days, 1 week later. Here, after that, the patient began to recover. And the first signs of recovery noted a few days after the initiation of the phage therapy. And during an 8-month post-treatment follow-up, there was no positive cultures for Acinetobacter or Klebsiella obtained from any site. And the patient's wound has closed with no pains or secretions. And this is a few words about the mutuality between this Acinetobacter and the Klebsiella, because this Klebsiella was almost always sensitive to the meropenem. But when it is along with this Acinetobacter, the production of the carbapenemase from this Acinetobacter will help this Klebsiella also to evade the meropenem. And when these organisms are together, they are actually both of these organisms are resistant to meropenem. Only the phage therapy along with this antibiotic together given, then only this bacteria growth was ceased. And in this case, there was no phage resistance developed among this Acinetobacter baumannii, fortunately. But later it was found that in the in vitro studies, there was such mutants were there. They are resistant mutants. And there were around 37 genes mutations in between these resistance and sensitive Acinetobacter baumannii species. But as I said earlier, there is a good news that even with this resistant Acinetobacter, we can find out this newer and newer bacteriophages against this resistant organism also within a period of weeks. So within a few weeks, the researchers were able to identify a newer bacteriophage which has again acting against this, even this resistant Acinetobacter baumannii. Actually, it was found out from a sewage water. So it is a ubiquitous organism. We can find it out from anywhere in this world. And these organisms can kill all the resistant organisms also. So the key point is that we can consider, even though it is in the developmental period and only in the research setting it is now given, phage therapy can be considered as an important development in the in this era of newer and newer antibiotic resistance. So in severe and non-responding infections, along with the antibiotics, even with high-end antibiotics, we can use this phage therapy without any further addition of side effects. And this resistance to this bacteriophage therapy is also well documented. So we should also be cautious in the bacteriophage therapy also. And the final case is again another bacteriophage therapy from China. Actually, but here it is another action of this bacteriophage, which is or another action of the antibiotic along with this bacteriophage is given. That is a synergistic action, because we know that most of the organisms will be resistant against older antibiotics like the trimethoprim sulfamethoxazole. But when we are giving it along with this bacteriophage, we can see that it can increase the activity of this bacteriophage against the very high resistant organisms and produce very good results. Here it is a 63-year-old female with recurrent UTI from China, and the bacterial pathogen was extremely drug resistant Klebsiella pneumoniae, and which was resistant to the almost all the antibiotic except tigecycline and polymyxin B. And she was having type 2 diabetes mellitus and hypertension. And the initial episode of UTI was in October 2018, which was initially led to acute pyelonephritis and infectious shock. So initially, she was treated with the tigecycline, and UTI was not cured because the in vitro and in vivo sensitivity may be different. And then the patient was not cured. And later it was changed to the levofloxacin and sulfamethoxazole, and only the complications increased, and not the condition of the patients improved. So the patient was again enrolled for the phage therapy, even though it is a chronic condition and not a life-threatening condition, but due to this increased complications and the patient was not able to tolerate all these therapies, and the disease was persisting, the patient enrolled in the phage therapy. And here the strain isolated from the urine was a Klebsiella pneumoniae strain. And again, the antibiotic susceptibility was like that previously. Tigecycline polymyxin was only sensitive. And here the phage spot test was done for these organisms, and around 5 lytic phases came as sensitive against this organism. And there was a regimen made by the treating doctors. Here they just withdrawn their antibiotic for the 5 days. And during these 5 days, the patient was given phage therapy from 9 to 13 of May 2019. And this cocktail was known as the cocktail 1, which was administered. That means all the 5 strains were administered as an equal 50 ml of cocktail. It was given by bladder irrigation. For the continuous local application, it was given as bladder irrigation. But even with that, there was a repeated reemergence of the resistant organisms. So again, they were thought about some newer therapeutic strategies. At that time, it was speculated that, some non-active or some resistant antibiotics may enhance the activity of these phages. So again, they had started a newer cocktail. That means with 5 or 6 lytic phages, they were selected with full coverage for these strains. Along with that, they started trimethoprim and sulfamethoxazole. Actually, this was resistant. That organism was resistant against this antibiotic. But for the synergistic action, they had selected this trimethoprim sulfamethoxazole. And the growth of these organisms already shown resistance to this antibiotic. But after starting in this, interestingly, this cocktail, that means moderate high dose. Here they have given 800 to 800 milligram sulfamethoxazole with 160 trimethoprim twice a day, along with bladder irrigation with the lytic phages. for 5 days from July 2 to July 6. That bladder irrigation was once a day, and the treatment with this trimethoprim sulfamethoxazole was for twice daily. And it was given because there was a notion that this cotrimoxazole is actually getting extremely high concentration in the urine than in the blood. So even if we are testing a in vitro sensitivity, it may getting a higher concentration in the urine, and the urinary tract infection may, all the pathogens may be sensitive to this antibiotic at that that much high concentration in the urine. So they are given along with that this antibiotic. Finally, it was noted that with this therapy, that means with this phages, with this cotrimoxazole therapy, the resistant Klebsiella species was completely eliminated, and his all recurrent UTI symptoms were disappeared, and there was no adverse event occurred during the whole period of phage therapy, and the patient was finally discharged without any further recurrence of the symptoms within the next 6 months follow-up. So the key point is that the bacteriophage therapy along with resistant antibiotic even we can try, and that may increase the beneficial effects in the of this bacteriophage therapy in some cases, and it may decrease the side effects because we are giving the multiple high-end antibiotics. They all have multiple side effects, and with this resistant antibiotics means their side effect is very less, and with these antibiotics and along with that bacteriophage therapy, we can increase the survival rate of the patient and decreases the side effects. So these are the 4 relevant cases in our newer, in accordance with our newer therapies against the organisms which are difficult to treat and very difficult to eradicate from our body. Thank you.
Thank you, Jitin, for that very interesting presentation. Of course, an insight into the phage therapy as well. That was very informative. Thank you very much, both Dr. Padmakumar and Dr. Jitin, for the excellent presentations. Now, coming over to the few of the questions which has been given in the chat box. One of the question is, we were taught that one of the reason for combination of ATT is to prevent resistance. Here it is stated that the combination of antibiotics increases resistance. Would you explain, Dr. Padmakumar?
Okay, sir, it's a very good question, because one of the method of judicious use of antibiotics is avoidance of antibiotic combination. That is, but unnecessarily combining antibiotics, that we had to avoid. For example, we should not combine a bactericidal antibiotic with a bacteriostatic antibiotic. But we can combine this 2 bactericidal antibiotics for their synergistic action. Example, the classical example is we are combining penicillin with aminoglycosides. But coming to the this anti-TB drug, this combination, because where we are giving a further combination, for example, INH, rifampicin, ethambutol, pyrazinamide. Here the topic is different. Here the peculiarity of this INH is that it will prevent the emergence of drug-resistant strains, especially to rifampicin, as well as especially to rifampicin and also to pyrazinamide. So when we are combining such a group of drugs, for example, INH and rifampicin, along with this pyrazinamide, ethambutol, etc., then the occurrence of the drug resistance is grossly reduced or mitigated. So the purpose of combining antibiotics is in TB therapy is the effect of INH, which will prevent the emergence of drug-resistant strains, especially to rifampicin. So the 2 points are different. We can combine 2 antibiotics when they are bactericidal, but never combine a bactericidal with a bacteriostatic drug. That is the conclusion, sir.
Okay. Incidentally, we have 2 guests from our neighboring state, Dr. Selvarajan and Dr. Abdul Kubos. Both have joined us, and I think Dr. Abdul was a regular visitor of in many of our CME webinars. And one more question. Is it correct that the Pfizer pneumonia vaccine does not have to be repeated after 5 years? That's a question. I don't know.
Yeah. Regarding this Pfizer vaccine, sir, it is a very effective vaccine. Now it is available as Prevenar vaccine. That is it's a single dose vaccine, sir. Usually it will be given as a single dose, single dose pneumococcal vaccine. But for children, it requires about 4 doses of vaccine is necessary to initiate the vaccination. But for these adults, single dose vaccine is sufficient. More than 18 years age, we can give this pneumococcal vaccine, this Pfizer pneumococcal vaccine, but there is no necessity of a booster.
Okay. Dr. Jitin, there's one question for you. Is phage therapy available in India or in Kerala for that matter?
There was in Delhi some private labs was doing bacteriophage susceptibility testing. I think they will soon start with this bacteriophage therapy in a common ways. But
So
they
it is
not started, only in the developmental stage.
Yeah, developmental stage. Okay. Okay, that's all the questions in the chat box. Anybody, Dr. Menon?
Menon is having some questions.
Yeah.
Unmute, Dr. Menon.
Unmute and speak. Unmute. Yeah, okay. You're unmuted from here.
What is the cost of phage therapy? Cost of phage therapy.
Actually, it is in the research period phase only. They are not doing it clinically, and they are all enrolled in a clinical trials. They are doing free of cost for these patients.
Yeah,
Yes,
excellent presentation by both Dr. Patnakumar and Jitin Raj. And today we heard about the phage therapy for the first time. And the cases were probably tertiary level or secondary level cases. But I'll come back to fundamentals. Suppose a patient with a fever, sore throat comes to you. Maybe you're a physician, GP, or an ENT specialist. What should be the approach? One thing. And second thing, a patient coming with dysuria, you have tested the urine and you saw pustules, whether you can start antibiotics. Is it Norflox or Cefixime? Or should we do the culture for every patient you are seeing? These are two questions I want to ask.
Thank you, sir. Thank you for the very fundamental questions. Any patient coming with an upper respiratory infection always doesn't need any antibiotics, sir. Because clinically also we can differentiate between a single viral catarrhal infection and a bacterial infection. If there is a definite focus of infection in the form of a sinusitis or a tonsillitis or whatever it may be, then we have to initiate an antibiotic. Otherwise, we have to educate properly the patient, and a simple analgesics and histamine symptomatic treatment is sufficient, sir. That is my impression. But we have to individualize the thing also. If the patient is an uncontrolled diabetes patient or patient having many other comorbidities, an elderly person, then we should not take any risk and we can start antibiotic even in the first visit itself. That is my opinion. And regarding the uncomplicated urinary tract infection, again, there is no need of doing the sensitivity. For example, a 17-year or 18-year-old girl presenting with a dysuria, frequency, fever, then we can straight away start gram-negative covering antibiotics. There is no need of any sensitivity, sir. But again, individualize. If the patient is uncontrolled diabetes, having some low in pain, we are suspecting pyelonephritis. In such condition, again, we have to send the patient urine culture and sensitivity.
One more question, sir. What is the relevance of Vidal test and Mando test nowadays? Is it relevant at all?
Yeah, regarding the first one, Vidal test is definitely relevant, sir. Still, we are doing it, and especially the clot culture also we will do, and it is very important.
Should we do blood culture or Vidal test to diagnose typhoid and all these things?
Both will be done, sir. In our center, we will do both viral test, we will do the antibody titer as well as the clot culture also. We will do. That is the thing. And regarding Mando test also, again, it will give some supportive evidence. If the patient is having all the clinical features of tuberculosis and high ESR, even rise of temperature, loss of body weight, appetite, and with a strongly positive Mando, with a induration as well as redness more than 10 to 15 millimeter, then we will definitely take it into granted, sir.
Thank you very much.
Okay, Dr. Selvarajan raised a hand. Dr. Selvarajan.
We just put the question in the chat box.
Is it? What was his question?
Shall I read? Why there is more
more reluctance and refusal to take up cultural and sensitive
Hello?
patients. Yeah.
Yeah.
Yes.
Yeah, the thing is, one may be the economical aspect may be there because the cultural sensitivity, it will be charging in the laboratory. That is another one factor. And another thing is this inconvenience. For taking the urine sample, sending it to the lab, etc., may be inconvenient to the patient. That is also another factor. I think proper education of the patient is very important, sir, in this aspect. You have to properly educate the patient why we are sending your sample for cultural sensitivity. And already Menon sir has asked, all patients may not require any cultural sensitivity. Only when it is indicated, when we are suspecting some severe infection or the background of the patient, then only we should send the cultural sensitivity. Otherwise, based on the common bacterial flora, and we can select antibiotics and we can treat it.
Who else has a question? Anybody else?
Regarding one question regarding the orthopedic infection is there, sir. Even though we said that the antibiotic course or the duration of treatment, most of the time is 5 to 7 or 7 to 10 days. In orthopedic infection, it is a different thing because here the duration is little prolonged treatment is necessary because the devitalized tissue, the bone, especially in osteomyelitis, etc., which is a devitalized tissue. The penetrance of the antibiotic is also very difficult. In such cases, we had to give 6 to 8 weeks of antibiotic treatment. Initially parenteral, and later we can even give oral antibiotic.
Sir, one question.
Hello.
One question,
Hello.
sir. Dr. Binoy here.
Yeah, Binoy, please.
Sometimes in orthopedic infections, we often encounter MRSA and VRSA, and we are short of antibiotics. Sometimes we send the patients home with Septran. They come back sometimes with good results. What's your take on that? MRSA and VRSA, when we have no other antibiotics to give them.
Resistant to both the methicillin as well as vancomycin.
Yeah, both.
Yeah, it is a difficult
It's not
situation.
uncommon nowadays.
Yeah, it is a difficult situation. Now we may try this linezolid. That is one choice because it may be effective. In our practice, when it is resistant to both methicillin as well as vancomycin, it's a very rare thing. Then we are trying this linezolid.
So it's a good drug, but sometimes we get away with Septran. That's the current. Sometimes we may get away.
Get away?
Yeah, sometimes.
Yeah, Dr. Selvarajan, you raised a hand again. Dr. Selvarajan, are you there?
Hello.
Yeah.
Am I audible, sir?
Yeah, audible.
Yeah, audible, sir.
Regarding the cultural sensitivity, most of the time the patients are very reluctant to take up the test on sputum or let it be urine, and that leads to a lot of difficulty in treating the patients. And as well, the tests are not available in the rural area, and the complications of resistance is more way to deal with those things, cultural sensitivity. How far we have to implement, sir? When hello?
Yeah, already we answered, sir. Probably you might not have heard it. Sir, there are reluctance from it is a very true fact, sir. Reluctance from the patient side we had to tackle, and the proper education is very important in this aspect. But as already discussed, in all cases, mild infections, there is no need of any cultural sensitivity testing, sir. Only when there is a complicated infection. And, yeah.
The pus in the diabetes wounds are the pus. What is the necessity of testing the pus in the diabetic wounds?
Yeah. And that is very important, sir. Very important. Very important. We had to do the cultural sensitivity. Most of the time it is gram-positive infections, but even then we had to do it. It's very important. In uncomplicated infections, for example, diabetic patient with a cellulitis, then we can treat without sending the sample. That is our message.
Okay, sir. Thank you, sir. Very useful presentation.
Dr. Srivilas. Dr. Srivilas.
Is it audible?
Yeah.
This question is to Pagwar, sir. Sir, your presentation is very excellent. My question is, how common is MRSA in tertiary care centers in Kerala?
MRSA is not an uncommon thing. The exact statistics we don't know, sir. It is not available also. But MRSA is now emerging problem in our this ICU patients also. This MRSA is an emerging problem. In such cases, we are giving this two antibiotics are now available. One is this vancomycin and the other one is linezolid. It's a common problem.
Yeah, I think as far as I know, the tertiary hospitals all have got MRSA. Most of them.
Yeah. Yeah.
Thank you.
Yeah. Then who else?
I've got one question. Can you hear me audible?
Yeah.
I've got one question to Dr. Padmakumar. Is it a usual thing to use tigecycline? Because I was given tigecycline 10 years back for a prostatic abscess. So the doctors were also a little bit confused about the culture report came as a Klebsiella gronin culture sensitive only to tigecycline. So they were also new to that antibiotic. So the nephrology department, they consulted with the pharmacology department about the dosage and all. And I was given 50 milligram in a drip, 100 ml normal saline IV for twice daily for 1 day, and then followed by 50 milligram for the next 4 days. So is this a common antibiotic these days we are using?
No, sir, it is not a common one. It is not a common one. In my experience, we used only in very, very rare conditions, especially complicated pyelonephritis and complicated cystitis, etc. But very rarely only, sir. Very
because
rare.
I was admitted with acute retention of urine 10 years back in one of our medical college. Then without any diagnosis, I was shifted to Baby Memorial Hospital. There I was examined under general anesthesia because in the meantime I was given all sorts of antibiotics because I have taken the third generation chloroquine, linezolid, piperacillin, Marapen, everything without any effect. Then ultimately I was taken to the theater. They examined me under general anesthesia and found that it was prostatic abscess, was drained, and the culture showed the Klebsiella gronin culture only sensitive to tigecycline. So
the right
I was
medicine,
given
sir.
tigecycline and then beautiful improvement with the first dose of tigecycline.
Probably got the right medicine at the right time.
Right. Because 1 month I was suffering. 1 month I was suffering without any diagnosis. With all antibiotics, they were not in a position to diagnose what exactly it is. So ultimately, my uncle, Dr. Roychal, he was in Calicut. So he said, I want to examine you under general anesthesia. He examined me under general anesthesia and found it was a prostatic abscess. He drained that, sent for culture and sensitivity, and the report came as it was sensitive only to tigecycline. So they were confused what the dose and all about the tigecycline. This was 10 years back.
Yes, sir. What was the organism? What was
this is
the
a
organism?
Klebsiella gronin culture, Klebsiella.
Okay.
Okay.
I think if there are no more things, we can wind up the session, I think.
Yeah.
Yes,
Anyone else?
Dr. Padmakumar and Dr. Jitin, I think we have got a lot of information, and we'll have a formal vote of thanks from Dr. Gopikumar.
Yeah. Respected State President and the esteemed participants of this webinar, I wish to thank both Dr. Padmakumar and Dr. Jitin, because that was a very short notice that we gave the instruction to have a CME on antibiotic resistance. Of course, the National IMA has given a template of presentations on which they could develop, but then they did a very wonderful job because very lucid presentations, very informative, and insights into newer techniques and other things. So both, thank you very much, Dr. Padmakumar and Dr. Jitin. And thanks to each and every member, including the state office bearers, the national office bearers. Of course, we thank Dr. Jailal and Dr. Jayesh Lele, Mathandavula sir, past state presidents, state office bearers, and each and every member who has participated in this and made a grand success. So I think we can call it a day. Thank you.
Thank you, everybody. Meeting is closed.
Okay, thank you. Thank you very much.